This conference will now be recorded.
Good morning, everyone. Am I audible? Am I audible or not?
Yes, ma'am.
Okay. So today we are going to discuss the among instruments. So list of most important instruments which we use in pediatrics or procedures which we do are lumbar puncture, bone marrow aspiration needle, intraosseous needle, bone marrow biopsy, thoracentesis, paracentesis, bag and mask ventilation, how to introduce a Rice tube, umbilical vein catheterization. So this is the LP needle. You can see a needle here. So it is a spinal needle. Coming to the lumbar puncture needle instrument, it is a sterile spinal needle with sterile 22 gauge, black length according to age. Usually black needles will be present. Length according to age 1.5 to 3.5 inch. Indications are diagnostic, CNS infections like meningitis, encephalitis to rule out subarachnoid hemorrhage, pseudotumor cerebri, GBS syndrome, inflammatory CNS disease like GBS syndrome. Installation, it is used for the installation of intrathecal dye for imaging procedures like myelography and measurement of the CSF pressure also. These are the diagnostic uses. So therapeutic, installation of intrathecal medications, example chemotherapeutic CNS prophylaxis in leukemia, tetanus, immunoglobulin in tetanus, rarely antibiotic in severe meningitis, and also for spinal anesthesia. Contraindications are elevated intracranial pressure owing to a suspected mass lesion of the brain or spinal cord, severe respiratory distress and shock, etc. If the child is present with respiratory distress or shock, you should not do an LP because the position may worsen the shock or respiratory distress. And in thrombocytopenia, any thrombocytopenia less than 20,000 of platelets, it is an absolute contraindication for LP. And if 20 to 50,000 only because of antibiotic, the child is stable, respiratory distress or shock also, you should think about if it is, you should see the benefit risk ratio. And usually less than 50,000 we don't perform an LP, and less than 20,000 is an absolute contraindication, and relative are 20 to 50,000. Local infection at the site, you should not do an LP. Lumbar puncture complications are post LP headache may come sometimes, and backache is also expected. Iatrogenic meningitis will come. Cerebral herniation in sudden drop of elevated intracranial pressures are seen. Cerebral herniation also will occur. Bone marrow aspiration. The instruments use a Sala bone marrow aspiration needle. What are the indications? Diagnostic diseases like leukemia to detect bone marrow infiltration and disorders like lymphomas and other non-hematological malignancies. To rule out the malignancy process in ITP before starting a steroid therapy. Bone marrow culture in diseases like typhoid and malaria, which is rarely done to rule out diseases. This is the Sala's bone marrow needle. So here you can see a screw type which prevents the deep entry of the needle. Here is the needle and it is the stylet. Procedure: patient is placed in prone position. Clean the area with iodine followed by alcohol and infiltrate the skin or subcutaneous tissue and periosteum with 2% lignocaine. Give 2 to 5 ml with boring movement. Introduce the needle into the cavity of the ilium at the center of the posterior iliac spine. Always giveaway feeling is felt when you introduce the needle correctly. So when the giveaway feeling is present, you think that you're sure that you entered the marrow contents. When site chosen is tibia, the needle should be directed away from the knee joint, as damage there can impair the growth of epiphysis. What are the causes of dry tap then? Myelofibrosis and aplastic anemia, you can expect a dry tap. So this is the ilium, and you have introduced the bone marrow aspiration needle like this, and when the giveaway is there, you have entered the bone marrow. First of all, you clean it and you give a lignocaine, and then you introduce the needle. One more type is Jamshedi trephine biopsy needle. Site is posterior iliac spine. Indication dry tap in bone marrow aspiration and suspected aplastic anemia and myelofibrosis. PS bone with the boring movement. As the bone marrow is reached, remove the stylet and advance the needle. To and from movement should be given, and obtain a bit of bone marrow. After taking the tissue from the needle, an imprint smear is made, gently rolling the tissue on a glass slide, which is then fixed and stained. So coming to the intraosseous access, it is a life-saving procedure to be mastered by all the doctors who care for children. See, if a child is presented to a casualty in shock and you don't get an IV cannula, nowadays don't wait for an IV access. Go with an intraosseous access, because it is a life-saving procedure. Even the shock can be treated, which prevents cardiorespiratory failure. And so don't wait for an IV access in a children with a chubby child or infants. You might not get an IV access fast. So go with an intraosseous access. It is a life-saving procedure, and most preferable site is 1 to 2 centimeters below the tibial tuberosity. Here you can see the tibial tuberosity, and 1 to 2 centimeters below, and just medial you can introduce the bone marrow, sorry, intraosseous needle. Use a 18 gauge bone marrow aspiration needle or even a blood transfusion set needle in infants during emergency. If you don't have an intraosseous needle, you can get a blood transfusion set needle during emergency time. Insert the needle at 90 degrees to the skin and penetrate into the marrow with a twisting motion, same like above. So you remove the stylet and aspiration. When you get the giveaway feeling, you are sure that you entered the bone marrow, and try to aspirate some marrow into saline filled syringe. If you aspirate, it is sure that it is in the marrow. Then infuse some saline to ensure the location and remove any clot. After that, you push a small amount of saline to ensure it is in location, there is no swelling. You observe for the swelling and remove if any, and it removes the clots also. Now fix the needle firmly using bandages. After that, you can infuse crystalloids like NS or RL, whatever how much you needed, drugs, or even you can give drugs like antiepileptics or drugs, and blood using standard IV tubings attached to the needle. But remember, when you give an intraosseous access, you should remove the needle preferably within 6 hours. If you don't remove it, they may get infected and osteomyelitis is expected. Next is thoracocentesis. Instruments which we use in thoracocentesis are needle 18 to 22 gauge over the needle catheters, 18 to 23 gauge, and specimen collection tubes, 3-way valve assembly, and a syringe 10 to 30 ml. Indications are pleural effusions, pneumonia with effusion or empyema, and suspected malignancies. Procedure: the child is made to sit and lean to a support. Local anesthesia is given and needle with a 3-way and syringe is introduced through upper border of a rib and aspirated. If the aspirate is pus or in large amounts, intercostal tube is to be placed. So this is the position. In a thoracocentesis, penetration site is 1 to 2 centimeters below the upper border of dullness area in percussion. Draw directly up above upper edge of corresponding rib. The patient is sitting in upright and leaning on table. Pleural space filled with excess fluid. Fluid collects in bag or a syringe. This is a thoracocentesis set. Thoracocentesis complications are pneumothorax, hydropneumothorax, hemorrhage, hypotension due to vasovagal response, pulmonary edema due to lung re-expansion, liver puncture or spleen puncture, air embolism, and introduction of infection. Ascitic tap paracentesis. A wide bore needle with a syringe and the 3-way adapter is used, and jet technique is used. Site chosen in junction is between the medial 2/3 and lateral 1/3 of an imaginary line drawn from the anterior superiliac spine and the umbilicus. So you draw an imaginary line from the anterior superiliac spine to the umbilicus, and between the medial 2/3 and lateral 1/3 you introduce the needle. Coming to the most important instrument which we regularly use is bag and mask ventilation. In bag and mask ventilation also you see like it is the most important part of the NRP. So what are all we are going to discuss is pulse oximeter, oxygen source, bag valve mechanism, mask device, cushion rim mask with variable sizes, oropharyngeal airways, Yonker suction catheter with vacuum power source. So bag and mask ventilation, the common pitfalls of bag and mask ventilation include inadequate positioning or inappropriate mask holding and failure to use an oral or nasal airway. So see the first diagram. It is the ideal bag and mask positioning is obtained by aligning the patient's external auditory meatus with the sternal notch. See, the patient external auditory meatus should be in line with the sternal notch. Traditionally, the EC hand position. See, you have see in the diagram, the first you can see the thumb and the index finger in a C position, and next all the fingers in a E position. This is best utilized to obtain the seal within the mask. So use a self-inflating bag. You are self-inflating the bag with a volume of at least 450 to 500 ml for infants and young children, and as smaller bags may not deliver the effective tidal volume for younger children. You can have different types of mask like bags like 250, 500. So in a small, very preterm child, you can use a 250 ml bag, but for infants and young children, to get the adequate tidal volume, use a 450 or 500 ml bag. In older children or adolescent, an adult self-inflating bag of 1000 ml may be needed to reliably achieve the chest rise. So in very older children, you can get a 1000 ml bag. So in bag and mask ventilation, 100% oxygen is to be used during resuscitation, titrate to greater than 94% once circulation is reintroduced. So this is the bag and this is the reservoir. In the back side, you can have two connections. One is for the oxygen and one is for the reservoir. And this is the pop-off valve or pressure release valve, and this is the mask. You can have a different types of sizes of mask like 0, 1 and 2. 0 should be used in preterms or the terms, and 1 and 2 for the adult sizes. What is the correct size? How do you know the mask which you are using is the correct size? Is the mask should adequately seal the nose and the mouth and a part of chin, but it should not cover the eyes. So a self-inflating bag, if it is not connected to anything, it delivers only room air, that is 21%. To achieve a higher oxygen concentration, so a bag also you can have two types of reservoirs, open-end reservoir and a closed-end reservoir. If nothing is connected and only room air is used, you get 21% of oxygenation. To deliver a high oxygen concentration, 60 to 95%, attach an oxygen reservoir to the self-inflating bag. Here it is with the reservoir. So it gives about 60%. Maintain an oxygen flow of 10 to 15 liter per minute into a reservoir attached to a pediatric bag and a flow of at least 15 liters per minute into the adult bag. So if you attach even an oxygen tubing and you give 100% oxygen, you can achieve more than 95% of oxygenation. So you have an open-end reservoirs and a closed-end reservoirs. Depending upon, you can see the oxygenation. Now, what are the contraindications of bag and mask? If a child is having meconium aspiration syndrome or meconium aspiration is there when the child is delivered, then you should not use bag and mask. And even in congenital diaphragmatic hernia. What is congenital diaphragmatic hernia? All the intestinal loops are present in the thorax. Already the lung is pushed to one side and there is oligemia. So the lung space is lost. Even if you inflate it with bag and mask, if you give the bag and mask, then it in turn compromises the lung space and leads to respiratory failure. So you should not give bag and mask in congenital diaphragmatic hernias and meconium aspirations. So one of the precaution, and again to prevent the excess entry of, if you do a bag and mask, the whatever air you are pushing enters both the trachea and the esophagus also. So better to keep an NG tube before giving a bag and mask and leave the end of the NG tube open so that it will push the air whichever enters the stomach outside. It prevents the pneumoperitoneum also. So next is feeding tube insertion. Indications are stomach aspiration or poisonings, etc. and also to give nasogastric feeding. Different sizes of feeding tubes are available. Number 5, number 10 are used of various ages of infants. So how do you measure the length of a feeding tube? The length to be inserted is measured from the nostril to the tragus of the ear and then to the xiphisternum. Once inserted, push air through the tube and auscultate over the epigastrium to check the position. Once after introducing, you check whether it is in the position or not, because if you enter into the trachea and if you give feeds, it will lead to lung aspiration. So here in the picture you can see an MDI with spacer. So this is the body, this is the wall, mouthpiece and a cap, and backside it is the inhaler. Use it for prophylaxis in persistent asthma. Correct technique is to be taught to the child and the parents, and parts to be explained clearly. So in MDI spacer you have the backside inhaler is the canister part. This is the canister part. This is the mouth attachment piece. In the canister part you can have a blue type and a red type. The red type is usually steroid, and the blue type if they're giving it is a beta 2 agonist. So this MDI spacer, why are we attaching this? We can directly inhale, right? We can directly use the inhaler. But why are we attaching this spacer also? Because inhaler in adult patients they can inhale correctly, but in pediatric children they can't take such an inspiration. So after pushing the drug from the canister into the body, it will take some times. You ask the patient to click the canister for two times or 2 puffs if they are given. Ask them to inspirate and slowly wait for some time. Allow all the drug from the body also enters the mouth. So even for small children, in very small children, less than 4 years, you can even use a mask which covers the nose and the mouth. Endotracheal intubation. Indications are assisted ventilation. Drugs can be given through ET route. Very important for surfactant administration in newborns with RDS. So what are the indications are? It helps in ventilation. In the NRP guideline, if it goes for an ET or the meconium suction, you can use it for ventilation. And what are the drugs which we use usually in the resuscitation? So like epinephrine, non-epinephrine, all the drugs which we use it through the ET route, and surfactant administration in preterms with respiratory distress syndrome. Most commonly, we give a surfactant administration. How do we give a surfactant? By the InShoot technique. You intubate the child, get a surfactant of various types of surfactant are there. I'm not discussing about it. So you want to give 4 ml, then you give in 4 aliquots, 1 ml. You introduce to a tube. After that, giving the surfactant, you give bag and mask, and again introduce 1 more ml. Give a bag and mask for distributing the surfactant evenly. Endotracheal tubes, uncuffed tubes are there and covered tubes are there. And these are the uncuffed tubes for your identification. Uncuffed tube starts with 2.5, 2, 2.5, 3, 3.5, 4, 4.5 like that. They are available. In extremely preterm child, you can give a size of 2, and according to the age of the child, you should adjust. And cuffed for older children. Umbilical vein catheterization. It is used in newborns for exchange transfusion and also as venous access for giving IV fluid and drugs, and obtaining samples in preterms where peripheral lines are not available. For inserting an umbilical vein catheter, prepare the umbilical cord. Insert the catheter into the umbilical vein. Umbilical vein will be smiling, and these are the 2 arteries. Arteries are usually muscular, and this is the vein which is smiling. This is the larger thin walled structure towards the head. Note the 2 umbilical arteries which are thick walled and towards the legs of the infant. Fixation of the inserted catheter which prevents the kinking. So next are the liver biopsy needle indications. Chronic, you want to introduce the liver biopsy, do a liver biopsy in chronic hepatitis, cirrhosis or storage disorders, malignancies or undiagnosed hepatomegaly conditions, to differentiate between the neonatal hepatitis and the biliary atresia. What are the prerequisites? You see first any coagulation defects are there. Prothrombin, get a prothrombin, BT, CT, blood grouping, identify the blood grouping and go for a cross matching even. And you also given vitamin K administration before the giving the drug. So before doing the biopsy. So Wim Silverman needle, liver biopsy needle, different types of needles are used. Wim Silverman, Mangini needle and true cut needle. So liver biopsy needle you can identify, if you want you can remove the needle from the skillet and you can see the double-edged. So liver biopsy procedure when using Mangini, after making a track with track maker, the needle is fitted with a 2 ml syringe containing normal saline and introduced. The needle is first flushed and then applying suction force. It is advanced further and quickly withdrawn. The specimen is then flushed out of the needle. So I want to show other instruments also which we are using. The second slide, it is showing bag and mask with even a oxygen reservoir and also a reservoir. So this is the bag, pop-off valve, mask of adequate size. This is the closed-end reservoir. In the previous diagram, I have shown you a open-end reservoir. This is the closed-end reservoir. Then this is an oxygen tubing connected to the oxygen. So if it is a closed-end and oxygen of full saturation is given, it will give a at least 94%, about 95%. This is the inhaler. This is the canister, and this is the mouthpiece. You can even attach a spacer and also a mask. This is a non-rebreathing mask. Here is the mask and this is the non-rebreathing bag and oxygen tubing. Non-rebreathing mask is the most effective to deliver 100% of oxygen levels to the child. Indications are children with respiratory distress and these are the laryngotubes. These are the different sizes of lengths of, this is the laryngotube body and these are the blades. Different sizes of blades are there. On these blades it will be marked like 0, 1, 2 and 3. There might be straight blades also and curved blades. These are all the straight blades I am showing you. According to the weight of the child or the age of the child, you can select the appropriate size. These are the ET tubes, ET tube and cuffed ET tube. This is the mask and a spacer, body and a canister. This is PEFR measurement instrument. So when do we use PEFR measurement is to diagnose asthmatics and also to monitor the treatment. How do you monitor the treatment? First of all, how do you do the procedure? You ask the patient sit quietly and introduce the PEFR machine and ask him to take a deep inspiration and exhale maximal expiration, followed by deep inspiration, followed by maximum expiration, and you get a reading. Take 3 readings, take average of the 3 readings or the highest of the 3 readings, and you have a chart with the reading and the height, and you see and you see at what level in the chart it is coming. So you send the child home. What are the advantages of this PEFR machine? You can send the child home, and after that, how do they monitor if the beta 2 agonist which you are prescribing is correctly acting or not? The simple technique of assessment is, if a child is present and sent home, you can advise a PEFR machine, ask them to buy a PEFR machine. After taking the beta 2 agonist, you can do a PEFR and see if the value is increasing or not. So it is a handy, portable and simple and a bedside technique. And also, when the child is presented to you in acute exacerbation, what you can do is to see the whether the medication is acting or not, you first see a level of PFR. After that, you nebulize the child with beta 2 agonist, wait for 10 minutes, 10 to 20 minutes, and after that, you can ask him to do the PFR again and see whether the improvement is there at least more than 20%. 15 to 20%. If improvement is there, then you think that the medication is acting on the child. This is a respirometer, and this is a rotahaler. You can see older your grandparents or something, this rotahaler, which they introduced a capsule here, and when they push the capsule inside, and then when they inhale through this netted, once it comes, the medication capsule goes out and the medication will enter. This is liver biopsy needle, already we have discussed, and this is the bone marrow biopsy needle. Intraosseous needle. This is neopuff, which we use in neonatal resuscitation. It is a handy, portable, and an effective measure which we can use in the delivery room while transporting the baby. It is very useful, and it can provide the peak inspiratory pressure. Neopuff. This is the oxygen. This is the body. This is the oxygen tubing which you can connect to the oxygen, and this is the tubing which we want to connect it to the ET or something and give the puff. See, this one is the oxygen hood, and this is the oxygen nasal cannula. Here you can see two entry ports to the nostrils. So these are examples of the low flow oxygen carrying devices. Nasal cannula, it provides about 2 to 4 liters of oxygen per minute, and oxygen hood, you can see this is the oxygen hood. There might be round or square ones, and you can see the vents, two vents are there. And if the vents are open, you open the two vents, you can open one vent and you can close the two vents. So oxygen hood delivers about 4 to 6 or 4 to 8 liters of oxygen per minute, and these are low flow oxygen devices. If you close both vents, you can deliver about 90% of oxygen. If you keep one vent open, 80%, and if you keep two vents open, you deliver only 60 to 70% of oxygen. Based on the requirement, you can open the vents. Where do you use this? In neonatal with the respiratory distress, or in pediatric also with respiratory distress, you can use this oxygen cannulas. This is an LP needle. See, this one is a BCG syringe or auto disposable syringe. You can see the black one. After introducing the drug or vaccine, it will automatically dispose. You can't get it for the second use. And what is the BCG dosage? 0.1 ml intradermal on the left deltoid region. So this is an auto disposable syringe, and schedule is at birth. This is an insulin syringe. Insulin syringe you can identify by the presence of units. See, here units are there. At the end you can see the units. And where do you use insulin? For daily subcutaneous insulin introduction, or in DKS. After giving an infusion, you can use it in subcutaneous insulin in DKA. So this is a penguin sucker on the right side, and this is a meconium aspirator used in preterms with terms with meconium aspiration syndrome. Preterms meconium aspiration is very rare, so you can use it in a term with meconium aspirator. So on the right side you can see an mucus sucker. How do you introduce? You don't introduce the mucus sucker directly into the mouth, then squeeze it. But before introducing, you squeeze it and then introduced, and you allow the bulb to expand so that negative suction is provided and all the contents are removed. You know, M followed by N, so mouth followed by nostril. So this is the nasogastric tube. This is the feeding tube. You can use it for aspiration of the amniotic fluid in the resuscitation, or taking for a gastric aspiratin tuberculosis diagnostic, or for giving any feeds. So other instruments which are expected are your IV cannula. There are different gauges of cannula: 18 gauze, 20 gauze, 22 gauze, 24 gauze, and 28 gauze. Everything you can at the back of the cannula, if you flip it, you can get the size, you can see it and tell. And IV cannula uses, indications are you can administer medications, and in shock also you can administer fluids. Whatever medication you want, you can administer, and fluid you can administer. And you can get an IV set also, IV set tubing for connecting the IV cannula to the RL or NS bottle. It is used. And also in pneumothorax, you can butterfly needle, you can attach it to the butterfly needle, and for installation of the medicines, that is the indication. And syringes also of different sizes you can get: 5 ml syringe, 10 ml syringe. You can see the back side of the syringe and you can tell the syringe. And what else are expected is a feeding bottle. Feeding bottle, so what are the feeding bottle disadvantages of feeding bottle are, you can introduce sepsis to the feeding bottle. The nipple is almost, you cannot, it is a narrow space and infections are common. And also colics are expected in a feeding bottle. So these are the instruments we regularly keep.